Our first speaker of the evening really needs no introduction. No matter where you sit in the women's health ecosystem, Professor Marjorie Jenkins is a powerhouse, having spent most of her life dedicated to women's health and now training the future generation of physicians. As a professor of medicine, she is the founder of the Laura Bush Institute for Women's Health, which is a biomedical research and health education institute spanning across 5 health professional schools and 6 campuses. Prof. Jenkins also served as the Director of Medical and Scientific Initiatives for the FDA Office of Women's Health, where she provided sex and gender scientific expertise within scientific programs. In addition to a medical degree, Prof. Jenkins also holds a degree in chemical engineering and a Master of Education in Health Professions. Prof. Jenkins is a well-recognized expert in sex and gender-based medicine, having authored not only 150 publications, but the important textbook of how to implement sex and gender into clinical practice. I believe she has the perfect magic to educate the next generation of physicians, not only in equitable healthcare, but also how to combine this with innovative thinking. Welcome, Prof. Jenkins.
To fix it. Well, hello, everyone. I am so honored to be here. I want to thank Dr. Klingman and everyone for inviting me. I have a quick 12 minutes to speak with you. And so I'll start by just discussing some of the basics around sex and gender. Of course, in my 20-year history in sex and gender research and education and clinical care, I begin with every cell has a sex. We know that there are 25,000 genes packaged in every human cell. We know that the environment impacts the way genes are, proteins, et cetera, are transcribed. Mutations can occur in that environment as well. So epigenetics. So really, when we ask, is there a male and a female genome? What is the extent of that difference? And really, what are the influencers of sex and gender differences in gene expression? But more so for me as a clinician, primarily, is that what are the clinically meaningful differences? So I tell people, since I've studied this sex and gender science for 20 years, I have a lot of tidbits in my head and factoids, but we need to boil those down to what are clinically relevant to helping our patients. So can personalized medicine be achieved when disregarding sex and gender differences, which is really the model that we have been building over thousands of years in medical and biomedical sciences? So I pulled this precision medicine report from our administration in 2015, and I just looked for the term sex and gender to see how they were being utilized. And this is what they said the report was about: developing a framework for creating and managing a large research cohort to understand the variables that contribute to health and disease. So sex was mentioned 4 times as a demographic variable only, a reportable variable, and gender was mentioned 4 times in relation to sex and gender inequality and gender identity. So in a major report from our own government and administration around personalized precision medicine, sex and gender were not given any credence as variables that impact clinical care and health outcomes. So I was at the FDA for 4 years before coming to the University of South Carolina. And during that time, the FDA brought the first gene therapy for leukemia into being, and it was tailored to the patient. So it was personalized treatment, and that utilizing the patient's own T cells. And I will share with you, when I went back to look at the pivotal trial that allowed FDA to approve this gene therapy, there were only 63 participants. Now, that really surprised me, given that they did not look at any differences but from the sexes, irregardless of the disease, which actually occurs in both sexes. So that was pretty surprising. And I looked here at some factors around sex differences. when it comes to our immunity and our immunological response to cancer immunotherapies. And you can see here there are very different responses. The female immune response is very hot. It's very aggressive. It's much stronger than a male. The tumor antigenicity is high in males and lower in females. And immune checkpoint inhibitors are less effective on their own in females than males. And the tumor mutation burden was more effective in predicting outcomes for women. And the therapeutic strategy for males would be to enhance the immune environment for that therapy and to enhance the tumor antigenicity for females. So that's much of all of the basic science that I really am planning to go over with you. But just to give you an example of how really critical it is that we look at the cellular level on out to the patient. So I really feel like we're speeding toward personalized medicine without application of clinically meaningful sex and gender differences research. And what's the evidence? Well, there are many, and I don't have the time to go through them with you. But for instance, endothelial dysfunction with normal coronary arteries, 7 times more likely in women. Men are underscreened and undertreated for osteoporosis. And in fact, our therapeutics have not been well tested in males in the United States. The FDA in 2014 recommended that zolpidem, a sleep agent, should not be given to women except for half of the maximum dose. Now, zolpidem was approved in the late 90s, so women were overdosing on zolpidem for decades, and the FDA had the data. We knew that women metabolized this drug at half the rate, but really didn't know what the clinically meaningful difference was. Well, we found that by looking back at the data for adverse events when women were sleepwalking, sleep driving, sleep working, having accidents, and higher morbidity and mortality with zolpidem. Women, when in relation to alcohol use, more organ toxicity with less amounts of alcohol and less amount of time. That's even more important for us in the U.S. as we are having an epidemic of women with alcohol use disorder. So here's an example from Cleveland Clinic of how bias actually impacts clinical care. The Cleveland Clinic looked at 490 men and 233 women coming into their emergency room. They looked at who received the standard of care by clinical guidelines, door to cath time, balloon time, which actually can save lives in a matter of minutes difference. And you can see that men were given the guideline treatment more often and also had a shorter door to needle time. And it resulted in a 6.1% higher mortality in women. Now, Cleveland Clinic is one of our signature cardiovascular centers, and it's a global cardiovascular center. So what did they do? Well, they implemented a stepwise protocol that nursing, triage, and the physician had to follow. So basically, this is what the steps you have to go through when a patient is diagnosed with STEMI. And we moved into, here's what they saw. So after the protocol, which you see here, you can see that women then receive the guidelines up to 80% of the time, 91 minutes door to needle, and 6.5 30-day mortality. Over here, 84% of men, so not that statistically different, and only 89 minutes door to needle. So both men and women benefited from this, and men had a 3.3% mortality at 30 days. So what did this mean? What do they tell us that this does? Well, this difference is actually the fact that they removed gender bias. They didn't give the provider, the nurse, the triage person the opportunity to insert their implicit bias into an anxious woman coming in thinking that she's having a heart attack. And so what the difference remained, which is the 6.5 to 3.3, while not statistically significant, is the biological differences. So that's how sex and gender come together to impact patient outcomes. So as Dr. Klingman mentioned, last year, we Actually, it could have been 2020 because we've been in the pandemic. But this book was published, and it was really, for me, a labor of love for me, for the science, for better care for women, for better care for men as well. And that we finally, I felt, had the knowledge and the ability to put into one clinical practice book the ability for physicians, nurse practitioners, PAs, et cetera, to look at our chapters and to really apply sex and gender today in their practice. So you will find that this book is very practical. At the end of every section, it has practice points that tell you things you can implement today and to make your care more personalized and more precise. So I think that is really important, and very proud of that work with Dr. Connie Newman and all of the 20 plus authors and experts that helped us to develop that textbook. In the textbook, you'll see the framework for implementing sex and gender into not only medical education, but also clinical care. And what we start with is really just going through that patient visit, whether it's inpatient or outpatient. And we have communication. Women and men communicate different, but let's not stereotype men and women. There's a masculine way of communicating and there's a feminine way of communicating. There are some males that communicate in a more feminine manner, and there are some females that communicate in a more male manner. I actually communicate in what would be a more masculine defined communication. So a physician and a patient that are speaking differently in their communication styles, the patient is likely to leave that visit not feeling as if they received high quality care and not feeling as if they were heard. And the history, knowing the differences between the male and female anatomy and physiology as you're doing your history and physical exam. And once you develop that differential diagnosis, choosing the tests that are appropriate for that disease process or that issue that you feel is happening to that patient, and making sure that that diagnostic test has been validated in women as well as in men. Most of our testing has been done in predominantly male environments. And treatment. So this is therapeutics, pharmacotherapeutics, biologics, devices, even lifestyle changes. Are those treatments proven to work as well in men as they do in women, and vice versa? And then monitoring the outcomes and knowing the outcomes and what the prognosis and what those differences might be between men and women in your patients. So these are 6 that look like very basic steps, but these are integral steps to us getting to a point where a patient feels heard, where they feel we've given them personalized care, and we have given them the best evidence-based treatment for their disease process or their health issue. So here's something that I'll end on, and it's called stacking. And it's really when women, mostly because most of the research and the male medical delivery model sort of marginalizes our women, but this includes when we have intersectionality of the social determinants of health. Women of color, low socioeconomic status, where there is no equity in that space. So beginning there, and the patient then enters the healthcare delivery system, and you find that they are not communicated with well. Maybe there's a cultural issue. Maybe there's a language barrier even. So you're not getting the full history. You're not understanding culturally how this disease is impacting that patient. And then going through the physical exam and lab and diagnostics. So when we look at here, I always go back to the heart attack, the patient with a heart attack or chest pain or back pain. So a woman comes in with back pain, suprascapular back pain, and she's examined and she's asked how she's doing, and she's anxious because she's heard that women are more likely to present with back pain than men with heart attacks, and she feels she's having a heart attack. So she's very nervous. So the communication might be that the physician goes, well, she's stressed and anxious and she's having a panic attack. And then on the physical exam, there's no musculoskeletal tenderness. She's fully able to move her arm. There's no pain elicited when you do the physical exam, but you're still, because of our bias, are thinking this is an anxious woman. Then we go into our labs and diagnostics, and we might order a troponin, but we don't order the high sensitivity troponin. And our lab may not have adopted the sex-specific high sensitivity troponin range, which is more likely to predict a myocardial ischemia in a female patient. And so therefore, the woman ends up with therapeutics that are treating something that we thought was happening down here, which her social determinants of health also impacted. And she gets treatment for something that will not help myocardial ischemia and will probably progress to a myocardial infarction, which could lead to morbidity and or her mortality. There are so many examples of this, and it just stacks. And when you get that stacking for women or for men, depending on the disease, then the patient's outcome will be not only less than optimal, it will be a dire outcome for that patient. So I definitely could not go through all of the things I think about when I apply this in a clinical setting, but just wanted to give you some ideas of how my perception and my perspective as a clinician and as an educator and researcher have evolved over the last 20 to 25 years. So that being said, evidence is provided through well-designed, well-conducted research and optimal reporting of the findings. We now have a textbook, a U.S. textbook, that tells very practically how primary care can implement this with clinically meaningful evidence. Healthcare is evidence-based, and our patients bear the burden of our systematic failure to advance the knowledge and clinical application of sex and gender differences. So I will share with you as a group, which I do at the end of most of my presentations, we do not have the luxury of moving slowly now in this field. Our patients cannot wait for us to do that. So I thank you, and I look forward to hearing from our fellow panelists. Thank you very much.
Prof. Jenkins, wow, for this inspiring talk. It is really a privilege to hear from you and to hear your insights and your wealth of knowledge. And I know that my book is on its way because I really want to just really learn more and more and more and try and educate our community on how biases can creep into everything they do, from research to development of solutions to clinical practice. So we really, really thank you, and we look forward to interacting with you in our panel discussion. Now over to you, Michal, to introduce our next speaker.